the Indian counterparts not really vociferously expressing the need of oral antivirals. So, what would be the comment on this line in line of the variant of concern?
No, I mentioned again in my talk, later part of talk, whether you want to control whether you want to end your isolations or not. That's more important because people want to go back to the work, particularly 5 days and 7 days. CDC says 5 days is fine and come out and use the 5 days mask. Indian government says 7 days. In fact, we also cut down the isolations initially 7 days. But once the antigen test is available freely, people start testing themselves. The antigen test previously within 5 days it is negative. But right now we are seeing the 7th day also, the double line is seeing and the T line, the test line is more dark. That means still the viremic is going on indirectly. And the antigen test is positive, it is more infectious to other people. When the people is more infectious, when the patient has got viremic. So the viremia is gone behind 7 days also. That is why most of the guidelines again rewritten says, don't end the isolations by 7 days, go up to 10 days. If you want to end the isolations, you need to check the at least rapid antigen test, see whether it's negative on 2 occasions so that you can come out of the isolations. Otherwise, you will transmit the disease. But where is the evidence lacking whether these antiviral medications can limit the viremic phase or not? But no trials so far conducted. You people are the best people to do some trials on whether starting the antiviral and check the antigen test, not necessarily the viremic phase or checking the PCR, checking the genomic sequencing. Viral load is a bit difficult. Right now, rapid antigen test is available. We can do the test, people starting a molecule, checking on 5 day and 7th day whether the viral load is getting disappeared or not, and put other arm, there is no antiviral medications, how they are doing it, whether the viral load is coming down or not. But theoretically, we are seeing in the last couple of weeks a variant of concern. The symptoms also lagging longer. People are having fever for 7 days, 9 days. Previously, 2 days fever is cutting down, but now fever is dragging. The sore throat is dragging. The symptoms of cough is dragging. So we need to do the trial, see whether patients who have started taking the medicines, symptom improvement happening or not, one hand, what happened to the antigen test, and if you got a good trial, do the viral load or PCR testing also to see what happened to the viral load. That will give the answer to the questions what you are asking me.
Yeah, so in that perspective, if I'm looking towards the real world settings and the diagnostic limitations and the availability of testing to be large, and obviously the gold mine of information you probably rightfully pointed out about the S status is the fact that yes, in case of ambiguity and persistence and probably otherwise the risk stratification being re-adopted, how would you look towards I wouldn't call it as a pill burden, but what will be the strategy or clinician to actually load the patient through the lens of a combination strategy? Because we do have a couple of options which are enumerated. That yes, in case we do take the call that yes, he requires or he or she requires a treatment, then basis the limitation of the virus signature, I mean, would we be looking towards a role of a combination?
No, the combination therapy, particularly people talking about the oral antivirals, they're talking about combination therapy may be the best answer people are talking. Again, we need data for the thing. And second thing regarding the pill burden, usually the studies showed women did well with Molnupiravir. But most of the time, the women's complaining about the pill burden, difficulty in swallowing, if writing it up. But so far, whatever prescriptions are generated, because of the COVID or because of the Omicron fear, people are taking, they're not complaining the pill burden. But this is the right time companies should start producing 400 milligram instead of 200 milligram, making 4 pills. It's a bit difficult. So this is a time we need to step up and release 400 milligram. If somebody with a novel idea, not novel idea, somebody can get the permission from DCJ for 800 milligram, 1 BD, that is an ideal thing. People are looking at it. So make 800 milligram, 1 BD. Lot more people will start taking the medicines. Easy to prescribe also. Otherwise, people say this is too heavy, too high doses. Particularly women has got difficulty. But the MOVE trial showed women has got more benefit compared to the male harm. So think about it. But so far, I don't have any concerns raised by the people about the pill burden. They not raised any concerns so far pill burden. But this is the right time. You need to move on, make 400, get permissions, and start moving to 800.
Yeah, so I mean, the other perspective was the fact that yes, we are looking towards some of this evolving evidence to speak about in vitro, I mean, otherwise lab evidence to speak about A consistency of the antivirals being not only correlated with their mechanistics as a mechanism action, which is probably intracellular, and probably otherwise conceptually be of greater relevance when you are looking towards its action against the variants. But looking at the other data points there for the parties, including the cocktails, uh, if given a choice and probably if given a concession that yes, if you have one arm of then looking toward another arm of co-developers being probably spoken as being right directed for Micron. Could this too be really be looking at as a combination strategy for the right case in case it is identified?
No, we don't want to combine the cocktail plus this molecule there. Whether you want the combination therapy with oral antivirals, people are talking about it, but the good oral antiviral right now is like a Molnupiravir in India, but other molecule is not available. But what the US and what the NIH guidelines are talking about, they want to combine with both the oral antivirals. For example, the Paxlovid that is acting at a different level. So that act at the protease inhibitor level, and this act at the level of reverse transcriptase inhibitor level. There's a different level there, RDRP. That level is acting at. That act at the protease, this act at the level RDRP. So the combination theoretically is possible because I may do a lot of HIV also. HIV also we are using combination therapy. TB also we use a lot of combination therapy. But drugs acting at the different sites, it is able to kill the virus more effectively. The viremia can subside. But it's very difficult to combine. Theoretically, yes, cocktail also acting at the outer level, and this is acting at the inner level. It's possible, but in US they're talking about combining this drug with Paxlovid so that combination has got much better or not, but it will take time and cost is major concern in Indian setting.
Yeah, rightfully said, because I think we have seen some cases of oral antivirals even within the class, that is with Favipiravir, probably as rightly said, as a combination.
The problem is Favipiravir also acting at same RDRB. It is a weak inhibitor of RDRB. This is not like a Favipiravir. This is mutagenicity increases a thing. It incorporates into the virus and make the virus replications incompetent. But Favipiravir just inhibit the RDRB. That's a weak inhibitor. We need to load the dose and we need to wait for a long time. It won't happen immediately. This is rapid one, that is throw one. And second thing, we need to load the dose with Favipiravir. Here, there's no loading dose. Favipiravir is just an RDRB inhibitor. This is not an inhibitor. This is make the virus incompetent. Replications incompetent.
Yeah. So I think the other aspect was looking into the consideration, the fact that yes, if you're looking towards, if not age group of less than 18 and otherwise, if not looking towards an obvious choice, which is an elderly and aged, and if you're looking at this age group, which is probably the reproductive age group, any special considerations as a word of caution when we already had the first wave and the second wave, when we had looking at the role of oral antivirals really being used and because of any lack of available options. So as a class, IDRP inhibitors, including that of Molnu, yes, Molnu has a differentiated additional action. Would there be any over and above word of caution when we're looking at this class of oral antivirals when subjected to use in this reproductive age group of individuals?
So I don't think pregnancy is a concern for you, for both male and female. They don't want to plan pregnancy for next minimum 5 to 7 days. Yes, this molecule is fine. If pregnancy planning is there, it's very difficult to elicit the history or something. This is not a molecule. And similarly, less than 18, it is not the molecule at this point of time. Then two more areas where I am concerning it. When diabetes alone is a risk factor, the MOVE trial, if you see, people who are diabetic alone use this molecule, the response is not great. But this is again only one RCT. But we need to have more data, so that's what I'm insisting. We need to generate our data to see whether diabetic alone is a risk factor, whether this molecule cut down the symptoms, prevent the progressions, make the viral load come down. We need to assess the data one. So diabetic is a concern. Diabetic alone is a concern. Patient has got diabetic, CAD, CKD, multiple comorbids. Yes, this molecule can be used. Diabetes alone as a comorbid, I need to concern about it. And similarly, the trial showed previously infected people. Again, this molecule is a concern. So the real area of concern, young people less than 18, people planning pregnancy in immediate next 5 to 7 days or something, that's a real concern for me. Then third concern is people who are diabetic alone as a comorbid risk factors. Then fourth one is people who are previously infected. It's a real concern. And people say like vaccinated people, the trial was not done. But we are seeing people vaccinated, 2 doses received, still progression happen. So we need to do the risk stratifications, remove the vaccination alone as a criteria for me. But according to the trial, vaccinated people will not work. So these are all the real concerns apart from the pregnancy and apart from the engage.
So that's a very pertinent point which has been highlighted, that we look at the current status of vaccination. I think it would be sufficing to say the fact that yes, we are looking towards a partial status. And probably the current streaming of publications, including in, I think it's in NEGMs, which has come in, the fact that the antibody titers are probably on the lower side, if not to anything to speak about, probably to give credence to hypothesis saying the fact that yes, there seems to be some sort of an escaping of the immune systems by the virus of concern. Is the fact that yes, mechanistically speaking, the oral antivirals seem to be better suited for their mechanism of action as opposed to any of the therapies which are right now being suggested for the high risk or maybe those mild to moderate cases. So do you foresee this data point when we are also looking towards the 900 patient point, apart from the 1,500 data point of the studies for Molnupiravir, saying the fact that almost 20 to 40% of these cases were N positive. And when we are looking at the data point which was giving credence to their authorization as an emergency use medication, in this subset of cases also, what will be your take home for the larger audience of India who are probably going to be at least one dose to be vaccinated?
Yeah, that's why I said, for example, the trials were conducted in the Western world, they're talking about unvaccinated, but here it's partially vaccinated, and we are not comparing the mRNA vaccine versus what vaccines I am using. Most of the Western world, they're using mRNA vaccines. Maybe because of the mRNA vaccine segment is a different sector compared to what the vaccine, the vector-based vaccine and killed vaccine, what I'm using. So it's very difficult to compare apple versus oranges right now. So they're vaccinated means they're vaccinated with mRNA, whether we are vaccinated with these vaccines. So we need to see whether ours is matching with the Western world or not. That's why we are insisting to do a bigger trial, Indian populations, where we can expand more indications rather than what the trial has shown. The trial has shown limited indications. Unvaccinated, people who got multiple comorbids, diabetes alone is not a comorbid, and people, young people avoid pregnancy avoid. But we need to expand and we need to do a proper trial and to see where to place this molecule. That's an ideal thing. So we need to consider it clearly and do the trial. Unless the clinical evidence is very difficult to promote everything. Instead of waiting for recovery, we need to generate our own trial instead of waiting for recovery for me. That's the bottom line I told in my presentations.
Yeah, and there seems to be one more clinical observation from the data point which has come in from the dose finding or the dose ranging study. If not even from the pivotal study, was the fact that yes, the viral clearance, and when we're looking at the viral load and the infectivity and the transmissibility, which seems to be a huge plus for the BA1 and BA2, is the fact that we have seen that the viral clearance has almost been to the tune of 98.9% by day 3 and almost about the same in the pivotal study by day 5, to say the fact that it seems to be a quicker and a lethal drug, which is probably called virolysis, if not just a stick action. So in what way would this year of difference or significance when you're looking at MD practice? Yeah.
That's why I said some sufficient group, they wanted to end the isolations little earlier for surgical reasons. They want to go for some surgical procedures, and somebody want to travel abroad. So they want to end the isolations little earlier. They want to ensure none of the family members going to affect it or not. So this is going to help. Instead of viral load, the simple thing, that's what I suggested, do the rapid antigen, check whether it's clearing or not. That's more important. On selected population, it is required. The viral load or the clearance is much for selected populations, not for everybody. On selected subset of populations, this parameter is going to play a big role to end the isolations, to plan surgery. For example, if you're a surgeon, you got a patient tested positive, asymptomatic or mild disease, you want to operate it early because the disease may progress for other reasons. You can give this molecule, see 3 days, and the viral load is coming down. If it's negative, you can plan the surgery a little earlier instead of waiting for 10 days or 14 days. Whether you want to prepone the surgery because of the emergency, this thing, that's what a small subset of populations we can plan. Can we have some questions from the attendees there? Because we are thinking so much of theory only there. What is practically the decisions are facing? So why don't we answer a couple? Because we are reaching almost 8:25 now. Any questions has come in?
Yeah. I think we were crystallizing the thoughts which are coming in through both the considerations. And yes, we have really covered almost all of them.
Okay, that's good.
Apart from the consideration. That's quite right. Yeah, so that's where I think we would look towards some home messaging and a liner for the audience at large. So we would like to invite your quick take-home comment before we look at the close of this session.
No, oral antiviral has got clear role. There's no doubt about it. And the Omicron 1 and 2 is not behaving mild infections for the last 10 days for me. The Omicron 1 and 2 in a selected populations, what I told earlier, above the age of 60, multiple comorbids, people who are vaccinated long time back, it is not behaving like a mild illness. So we need to treat the viral infections, provided the patient presents to me yearly. Whether we want to use remdesivir versus molnupiravir depends upon the select set of populations, access to the hospital or not. Based upon the thing, we need to decide whether we need to give medications or not. But the bottom line, we need to plan bigger trial to demonstrate Indian benefit, because Indian population is huge, Indian population is different. So we need to have a good trial instead of looking at a move out or looking at a recovery. We need to start a trial. But pharmaceutical companies, yes, they need to invest in the small trial, at least not a big trial, small trial, multi-centric trial. We can enroll the people, do the study, show the scientific evidence, and prescribe or enroll the rational prescriptions rather than prescribing blindly. So scientific evidences need to be created. You need to be one of the leading pharmaceutical companies. Try to invest in a trial. That's what my advice for you, to take home message for me. Nice thing.
Yeah, so I think while we were addressing most of the queries, just a couple of them which came in right at the last moment. And probably I think one suffices to say the fact that yes, it's a clinical picture, 17-year-old boy, persistent fever even on the 5th day with a cough and a CRP of 54. And it's an unvaccinated status, so should we admit? So thankfully the oxygen saturation has been mentioned over here, that's normal. So I think that was a giveaway to say the fact that yes, unless you want to have a comment over here. Yeah.
So actually 18 years but unvaccinated, but usually some of the children we came across, for example, the less than 18 years, but a lot of comorbid type 1 diabetes we are seeing, and some of the young diabetes, type 2 diabetes also we are seeing nowadays in people within 13, 14. And apart from the diabetes, they got other problems, congenital heart diseases presentations, they got seizure disorder, they got asthmatic. We came across a sufficient, because I do pediatric ID also. So less than 18, a lot of young people with multiple comorbids, what I do, asthmatic, along with some other risk factors, some vasculitis or some connective tissue disease, taking steroids for the Kawasaki disease or something, they're taking the disease. So that's a big challenge right now. But this trial, because of the cartilage is getting affected with the molnupiravir in animal model studies, not in the human model, but in animal model studies, it demonstrated cartilage damage is possible and mutagenicity is a concern, carcinogenicity is a concern. So for children, it has got not approved right now. So the option for this type of cases are children less than 18 years, multiple comorbid conditions. If you want to treat unvaccinated, if you want to treat to prevent the complications because of the risk factors, use right now IV remdesivir. But the challenge is how to bring the child for daily administration. That's a big challenge. Otherwise, we need to use budesonide. That is another option available. But budesonide, usually the efficacy is not great compared to these two molecules. Some of the clinical guidelines, they remove the budesonide. But other option is budesonide for you. You can use budesonide to treat this child, but not azithromycin, doxycycline, ivermectin, please.
Yeah, I think that's rightfully highlighted about the pertinent need. And I think the couple of more questions to say the fact that yes, even if we look towards the choice for therapy, is there any background to the perception or hypothesis to say the fact that yes, remdesivir, favipiravir, moravir, would they be actually the rightful strategies for the variant or the variant of concern, basis their mechanistic acts? So, any comment on that?
Yeah, remdesivir is an IV antiviral. It's got a good role. Previously, we are using little late remdesivir. The patient is hypoxic. That point of time, we used it. That is why in solidarity trial, one of the participants, I'm one of the principal investigator for the solidarity, it failed. But if you are using little early, it is an IV formulations. It reaches pharmacokinetics and pharmacodynamic is good. We can use it. Only thing, the liver parameter, kidney parameter, we need to monitor and IV administrations. Favipiravir, I told earlier, this is a weak molecule. This is an inhibitor. We need to load. It will take some time to kill. And a lot of issues going with the Favipiravir. And there is no big data for Favipiravir. Even though it is available for the last 1.5 years, 2 years, still there is no big trial or no RCT showed it is going to work and kill the thing. And we all know already the RCT has shown the benefit. But we need to have a bigger studies to compare. If you want to have head-to-head comparison, we need to plan. There is no head-to-head comparisons. So we need to wait for like a bigger trial data comparing head-to-head. Remdesivir versus Molnupiravir is going to emerge soon, but I don't think so. Favipiravir is going to have a data in near future. So between Remdesivir and Molnupiravir, we need to choose.
And there's one more last case profile. I think we can take this before we really rightfully close. Is the fact that again it's a clinical dissect and a dilemma. If not for an age group of 18 and above, it's probably looking at 60 years and below, and that is 58-year-old female with states of fever, COVID status identified as positive. So should we admit and look towards the comfort of remdesivir and observe, or how do we proceed in such a case?
What the age you wrote? 58.
Yeah, that's right.
Yeah, 58 age is not okay, but we need to put the risk scoring. I told the risk scoring based upon the age, based upon the vaccinations, based upon the comorbidity, diabetic, hypertensive, coronary heart disease, CKD, COPD, CLD. More than 3 comorbid conditions, age more than 60, but less than 58 and 60 is not a big deal. And third thing is vaccination status. How soon they are vaccinated? Unvaccinated, good, you can straight away. Vaccinated, how old is the vaccinations? More than 9 months over, yes. More than 6 months also, I should prioritize provided the patient has got 3 comorbid conditions. 3 comorbid conditions, vaccinated more than 6 months back, it becomes a moderate risk to me. The moderate risk, I'll involve one-to-one discussions with the patients. This is options available to you because female molnupiravir harm did very well. So if the patient wants to stay at home, and we can take the medicines because 58 pregnancy is not a concern to me. And people are not infected in the past, and diabetes alone is not the risk factor. I can initiate a discussions and suggest molnupiravir. If they really wanted to take highway remdesivir, we are giving nowadays outpatients remdesivir also we are providing now. So we need to have one-to-one discussions and trial, and we need to enroll at least in a small study. I'm saying this is a trial basis. I'm using it. We need to tell them.
Yeah, I think this case was also speaking about no risk factors, but I think some of this is coming in. But I think that's where I think we'll look towards the close of this session and probably come back with further extensions as the case experience gets built up with the role of these compounds and functions and strategies. As wonderfully highlighted, there's a case space for each of this. And looking at and real world evidence evolve as rightfully highlighted, I think time will only put that point across. So we need to stay safe, stay healthy, and probably otherwise stay vaccinated. And before we actually start looking at dissecting the available options for their use in the real world settings. So thank you once again for that wonderful delineation and a dissect and a decode of the current strategies, both contemporary as well as, if not, the real world sense of India, if compared with developed countries. We are looking to the consistency of this scientific programs to give you real world perception and real world updates. And I hope the COVID time, which was invested over here, is probably not going to be wasted, but it's going to be only enriching for one and all for getting this clinical pulse into action in our clinical practice. So with that note, I would thank one and all, including the esteemed faculty, for this session, and hope to get back to you once again for yet another edition of this webcast. Thank you.